So thank you everyone for joining us today for our webinar on COVID-19 vaccines and implications for GBV prevention and response in humanitarian settings. I'm Lee Ashley and I'm the Regional Emergency GBV Advisor, or REGA, in the Asia Pacific region for the GBV AoR, and we are hosted by UNFPA. And I'm going to be your moderator today for this discussion. We really are happy that you're here. Before we get started, we're just going to review a few of the accessibility functions. So Shiva, if you could take us to the next slide, please. So we have closed captioning available today for anyone who would like to use it. And to activate this function, please go to the bottom of your screen where you see the CC icon or closed caption icon. Click on it and then turn on view subtitles. And then you can adjust to your own preferences. We do ask that you please turn off any speech to text applications on your phone because that interferes with the captioning. We also will have sign interpreters available today. You will see Daniel and Elizabeth on your screen there. And if you'd like to make them more visible, please hover over their photo and you should have an option with 3 dots. Click on those dots and then enter the pin video option. And then you can see them more visibly on the screen. And I just also wanted to note that we will be recording the session today and it will be available on YouTube and through the GBV AoR website. And with that, let me hand over to Jennifer Chase, our Global GBV AoR Coordinator, to welcome us and for our opening remarks. Over to you, Jennifer.
Thank you, Lee Ashley. Welcome to the Gender-Based Violence Area of Responsibility webinar on the COVID-19 vaccine and implications for GBV prevention and response in humanitarian settings. As Lee Ashley just introduced me, I'm Jennifer Chase. I'm the GBV Global Coordinator for the AoR based in Geneva. So it's wonderful already to see so many colleagues, familiar names in the chat, and we're excited about this webinar today. I just want to, it's been about a year now since we hosted a webinar series by the Riga. It was 5 different webinars where we gathered together GBV practitioners to ask questions and, more importantly, to together come up with solutions on how we could respond to this new type of emergency, which, as you are well aware, spans across the humanitarian and development contexts. As a result of these discussions, we developed new guidance for remote service delivery, leveraged our collective advocacy, and worked towards better inclusion of persons with disabilities, LGBTI, and women-led organizations. You, the participants, took those initial conversations and you adapted and implemented field-level solutions. Our webinar today is in the same spirit. This year, we find ourselves in a new phase of the pandemic. We need to ask a new set of questions, and we need to harness our collective knowledge to find new solutions. We are meeting here with you to think about how we can sustain our GBV response, recognizing that COVID-19 continues to affect the most vulnerable communities in humanitarian settings in tragic and inequitable ways, even as we have the hope before us of a vaccine to combat the virus. The UN Secretary General has stated that achieving equity in the COVID-19 vaccine availability is the biggest moral test before the global community. We must be sure that no one is left behind, and that means we must put protection at the center of the vaccination response. While GBV has been widely recognized as a pandemic, shadow pandemic, or also parallel pandemic, we still have much work to do to implement our humanitarian response in a way that prevents and mitigates the risks of GBV during COVID-19 and beyond. We have enough evidence to know that gender inequity and GBV is occurring right now at alarming levels, where vaccines are being deployed. The reality of this violence is that it affects the decisions of individuals, households, and communities on how, when, and where they access healthcare and humanitarian assistance. We know from our public health crisis and disasters such as Ebola that GBV risks, in particular sexual exploitation and abuse, need to be proactively prevented and addressed. And we know that we do not have to wait for more evidence to respond. We are bound by our commitments to the IASC GBV guidelines to act, and you're going to hear more about that in this panel. We must ensure that protection of women and girls who have been disproportionately affected by violence during lockdown and in the midst of declines in peace and socioeconomic well-being. This event is timely and critical as vaccination planning and deployment is underway in multiple humanitarian contexts as we speak. I think you heard yesterday that Ghana was in the headlines as the first country that WHO provided the vaccines as part of their program. I encourage everyone to use this webinar as an opportunity to explore your ideas and reflect on lessons learned. We have an excellent, esteemed group of panelists today who will share their experiences. They will help guide us in identifying the most important questions to ask and define how we can engage effectively in advocacy and with our counterparts at field level to ensure that vaccination campaign produces the best outcomes for all. At the end of the discussion, we will summarize the key points emerging from this dialogue and share draft guidance and tools for your inputs and adaptation to your context at the field level. We look forward to a fruitful conversation. And with that, back to you, Lee Ashley. Let's get started.
Thank you so much, Jennifer. So Shiva, if you could take us to the next slide. I just have a few more points before we dive into our first panel. Please indicate your name, designation, and agency in the chat box. Thank you, Dr. Safi, our national NGO co-lead in Afghanistan, for starting us off by putting your name there. Please also use the question and answer function at the bottom of your screen if you'd like to raise questions during the webinar. Please note that the recording of the webinar, as well as the materials we discussed today, will be available afterwards in a public folder and will follow up by email as well. Also, to ensure that we focus during this very brief time that we have together, I want to flag that we will really be discussing the impact on affected populations and frontline GBV service providers as well as services. And we will not be discussing access to vaccines for international humanitarian workers or any specific individual. And finally, in line with our GBV guiding principles of confidentiality and respect, we will not share any information about individual GBV cases. So that's our rules of engagement. Let's move on. I just want to give you a sense of where we're going today with our agenda you see there. And as Jennifer noted, our primary objectives are really to explore the questions we need to ask to identify the advocacy points that we think we need to utilize and the actions that we need to take. And you can see from the agenda here, we're going to explore that from different angles. And we're really going to try to ask and answer the questions about what are the GBV risks that may occur because of the dynamics of the vaccine. What are some of the potential impacts on the continuity of GBV services? What actions should humanitarians take in order to mitigate the risks of GBV? But also we need to look at what are the opportunities to make sure that we raise awareness and also ensure accessibility to GBV services throughout the vaccination period. So with that, I think I'm going to dive us into our first speaker. Sophie Harman is a professor of international politics at Queen Mary University of London and a global health politics expert. And she's really going to walk us through an article she recently published in The Lancet that has raised attention to the specific security dimensions of vaccination for women. So with that, I am going to hand over to Sophie. Over to you.
Thank you so much. Thanks, Lee Ashley, and thank you everyone for joining us today. So now, over 1 year into the pandemic, we already know that COVID-19 has been highly gendered with respect to infection rates, death rates, care burden, and the socio-economic, political, and security consequences of the crisis. And vaccines are no different within this. So in early 2020, a group of researchers and I formed the Gender and COVID-19 Working Group with money from the Canadian Institute of Health Research to really investigate some of the gendered impacts of the pandemic. Now, some of these findings have pretty much been ignored. Everyone knows what the outcomes are, but really there are not many policies addressing these concerns. So when the vaccine became available, we were very concerned that issues of gender and particularly security were taken into consideration. This is why we drafted the small piece that you may have seen in the Lancet that appeared earlier this year. This Lancet piece very much focused on the delivery of vaccines and particularly women's security. We are very interested in who facilitates vaccine uptake and the formal and informal care structures that surround that. We were really also concerned about out-of-pocket expenditure, increased burdens on women, and gender norms as to how people seek out access to healthcare. These are issues that are very much exacerbated and made more complex in humanitarian settings. For example, how do people access vaccines in a humanitarian context? Do they need to have permission from the male-headed household member to be able to access healthcare? The other issue we were concerned about was healthcare workers. We are really concerned about the safety of frontline healthcare workers and the additional burden put onto their time in having to deliver the vaccine. And finally in the piece, we reflected upon the very pertinent issue of sexual exploitation and abuse, drawing on examples of the Ebola vaccine and the Democratic Republic of the Congo. We already know that this is a concern. However, how do we therefore ensure protections around this? Now, I know some of my other speakers are going to be going into these issues in a bit more detail, but I just want to reflect on some of the things that we actually missed in the Lancet article or didn't really have the space to include. The first one is, of course, uptake and the need to think about uptake of vaccines, particularly in humanitarian settings. When people think about uptake, they tend to think about vaccine hesitancy, access, and prioritization. However, in the humanitarian context, we need to think about where people access the vaccine, who delivers the vaccine, and when they are able to access the vaccine, all of which are underpinned by issues of trust, risk, and safety. This is why it is fundamental to have both GBV and humanitarian experts in wider discussions around vaccine rollout in these contexts. The other issue of uptake, of course, is priority of who gets the vaccine. Now, this is very important when we think about healthcare workers and humanitarian care workers, healthcare workers and humanitarian workers, particularly GBV frontline workers. When we think of prioritization, we normally think that that would go to, say, the healthcare workers delivering the vaccine. I think there is also a clear case to make that GBV service providers should also be prioritized within this, because they are going to be working alongside those that are involved in vaccine delivery. The other issue we want to think about priority of who gets the vaccine is some of the data around gender and COVID-19. We know in humanitarian contexts that infection rates tend to be higher among the male population. So in, for example, Yemen, 75% male, Chad, Central African Republic, Pakistan, Afghanistan, Somalia, also 74% male. Now that would suggest that in humanitarian settings that men should have priority to the vaccine because they're most affected. However, we have to take a step back from this and think about what that data represents. Does it suggest that it's more men who are affected, or is it suggesting that it's men who are seeking out healthcare? And actually we have another kind of hidden shadow problem of women who are also infected but have not been actually captured by the data. My point here is not to discredit the data, but suggest that this can be used in very specific ways when talking about prioritization that may actually exclude women and those very vulnerable women that those of us who are concerned around GBV are really trying to capture. And as we know, the data doesn't capture everyone. So this is around uptake. Finally, the other issue we were unable to explore in the Lancet piece, which I think is very important, is the distorting impact of COVID-19 on existing vaccine and immunization efforts in humanitarian contexts, and also wider programs on GBV. So COVID-19 in international relations terms is like a hegemon or a succubus. It sucks everything in. And we've seen this from previous health emergencies, such as Ebola, such as Zika. We need to make sure that COVID-19 does not distort away from existing immunization efforts and existing GBV efforts, but really works alongside this. I'm sure many people on this call and in this webinar today have had their whole work completely skewed to now doing COVID-19. Everything is COVID-19, which is understandable, but that entirely comes with risks as well. Now, I just want to finish up with thinking a bit around some action points. I think we're all quite familiar often with the issues, but what can we do at this stage as we're really at the cusp of seeing this kind of mass rollout of the vaccines, or hopefully mass rollout of the vaccines? Firstly, we need to see a prioritization of GBV service providers for the COVID-19 vaccine. This is fundamental. We knew that female humanitarians working on GBV were at greater risk during the early outbreak through lack of access to personal protective equipment, PPE, and associated access to resources. They cannot be left out of provision of the vaccine. Second, we need to have full engagement of GBV experts in the vaccine rollout in humanitarian contexts. They absolutely have to have a seat at the table. And that's not the side seat, as in, so the GBV tick box or the gender tick box. This absolutely has to be fundamental to vaccine decision making. Sexual exploitation and abuse training and a side code of conduct for all vaccinators in humanitarian settings. We know that this is part of the UNFPA checklist on COVID-19 on sexual exploitation abuse. We need to ensure that all vaccinators have signed this code of conduct to avoid any abuse of power or increased vulnerability. The COVAX humanitarian buffer, we know is very welcome, so that's great. But again, we need to have clear provision within this buffer for the GBV sector. This is a key action point that I think we could be lobbying for and having negotiations with COVAX to say, okay, you have this buffer, we really need a clear budget line there for GBV. And finally, before I come to my last minute, which I note I have, is that we do need data on who is getting the vaccine in humanitarian settings. But I would absolutely echo Jennifer's point on this issue of data and evidence. We cannot allow excuses around data or evidence to be a reason not to invest in GBV. We know how hard it is to capture data on GBV. There cannot be, from the health side, this idea of give me the data and we'll act on it. We have to trust each other that this is an issue. We have to trust alternative sources and methods of research to be able to identify this problem. Finally, I just want to conclude on some promising signs. In comparison to previous health emergencies that I've conducted research in, we are seeing greater collaboration between the health and humanitarian sectors, where in parts that tended to be separated out a lot more. So this is very promising. Second, as I know my colleague Tanya Fraser is going to talk about, there can be positive outcomes for GBV emerging from health crises as people start to see and recognise the scale of the issue. So targeted interventions can lead to positive health outcomes if they are done properly with the right people involved in decision making and structuring the agenda. Finally, Gender-based violence, GBV, is not separate to COVID-19 vaccines. It's not an add-on. It's fundamental to seeing successful uptake of the COVID-19 vaccine around the world. Thank you very much.
Ashley, you're muted.
Thank you, Sophie, for those comments. Much appreciated, and we're noting down those recommendations for action points. We now will take a 30-second moment of calm, which will allow our interpreters to also have a break and for us to reflect before we move on to the next speaker. Okay, thank you. So next, we would like to continue this conversation and introduce our speakers from the World Health Organization. We are delighted that they've joined us today from the Eastern Mediterranean Regional Office. And our panelists will give us an update on COVAX, as well as provide us with their reflections and recommendations on gender issues that we should consider in the effective deployment of the vaccines from WHO's perspective. So Dr. Hoda Langar, the Regional Advisor for Access to Medicines and Health Technology, as well as Anna Rita Ronzoni, the GBV Technical Officer, will be presenting. So the floor is yours. Dr. Langar, please go ahead.
Okay, thank you. Hello, good morning, everyone. Shall I share my screen or you will? Okay, thank you very much. Really many thanks to the organizer for inviting me. And I have the pleasure to give you some updates, a brief overview on the COVID-19 vaccination situation. So as of yesterday, this is the data from yesterday that currently there are more than 1,111,800,000 confirmed cases, with more than 2,480,000 deaths. And the new cases yesterday reached around 327,000 new cases. The rate of, with regard to the gender, the rate of women versus men, men are more affected than women, 53% against 47% for women. And what we know, and it was published, that when it comes to mild or moderate cases, women are more affected, but for the serious cases, what we notice, it's the male, the men have more than, they're affected with complication and being hospitalized, particularly when it comes to intensive care. And women are really less affected by the coronavirus disease when it's a serious disease. Next, please. This is just a situation by region, and the Americas are the most, America is the most region affected. After that, followed by Europe, South Africa, Eastern Mediterranean is in the 4th position. And we don't know why Western Pacific may be due to the weather, or it's less affected, or maybe they are taking more precautions. Next slides. As all of you heard about the accelerators, which is this new innovative global collaboration to accelerate development, production, and equitable access to COVID-19 tests, treatment, and vaccines. This COVAX pillar, in fact, this accelerator is organized into mainly 3 pillars of work, as shown here. And one of them is the vaccine pillar. It's the first one on the left. This is mainly convened by the CEPI. This is the CEPI, it's for Coalition for Epidemic Preparedness Innovation. They are in charge of the development and manufacturing of the vaccines. Gavi, which is in green, this is a global alliance and involved in the procurement and delivery under this COVAX facility. And WHO is really taking care of the policy and allocation. Look, this ACT Accelerator and COVAX facility, the main supporting the building of manufacturing capabilities, buying supply ahead of time in order to accelerate equitable access to quality, safe, and efficacious vaccines. And we are targeting to have 2 billion doses this year in order to protect high-risk and vulnerable people, as well as frontline healthcare workers. Next, please. WHO and the COVAX facility, in fact, with all partners, worked to ensure a fair allocation to establish a fair allocation mechanism in order to have initial proportional allocation of doses to all countries. And we are targeting to provide 20% of the country's population, and to expand this coverage later for other populations who are not at risky, and to really manage the portfolio of vaccines, ensuring different vaccines to be available, and to deliver this as soon as they are available in order to end with this pandemic. Next, please. This is, of course, was based with the work in WHO, and this work was mainly led by the Strategic Advisory Group of experts, SAGE. They are specialized experts on immunization, and a framework allocation was developed where prioritization roadmap was established in order to identify the public health strategies and target priority population and groups based on, for vaccination based on the epidemiologic situation and vaccine supply scenarios, and come up with vaccine-specific recommendation. Each time SAGE was giving a recommendation when we have a vaccine approved by the regulatory authorities and also by WHO. And this was mainly to reach the goal of having a COVID-19 vaccine to contribute significantly to the equitable protection and promotion of a human well-being among all people of the world, regardless of the gender, regardless the economy of the country. Next, please. This is just, I put here the roadmap. We started with this COVAX facility since June 2020. We have currently 190 confirmed or eligible countries participating under COVAX. And after having first approval of some vaccines, WHO recommended for emergency use listing as of today Pfizer vaccine and also 2 vaccines, AstraZeneca when it's manufactured in India, and the other one in South Korea, Covishield in India and SK Bio in Korea. And the rollout started, as it was mentioned this morning. Ghana is the first country getting the vaccine, but the target of WHO and of our DG under COVAX facility is to have a rollout of the vaccine campaigns in all countries by 12th April this year. Next slide, please. It just, the goal is, of course, to reduce the mortality in the countries, particularly when it comes to priority population, and the whole allocation was based on prioritization of the population. The first one, it will be the healthcare system workers. After that, all elderly people who have more than 65 years old. And also after that, it will follow with the high-risk adults with the comorbidity. And here, as you can see, the different share for each type, each group of population, risky population. Next, please. How this COVID-19 vaccine allocation worked. In fact, we established 2 phases. The first phase will be this year, and this, from now, proportional. It's the proportional allocation up to 20% of total population. All countries will receive progressively the doses. And this is, of course, will depend on country readiness and availability of doses. For this reason, you will hear that a group of countries, they started getting the vaccine, and the distribution was given for some countries, and it will be followed based on their readiness for the time being. After that, we have phase 2. And this will be an allocation after the 20% based on the availability of the vaccines. They will get, the countries will receive doses at different rates. And this is mainly based on consideration of vulnerability and COVID-19 threat. And of course, countries with higher risk will receive the vaccines, the doses faster than others, and all vaccines that will be distributed will be, of course, recommended by WHO, what we call the WHO emergency use listing vaccines. Next, please.
Thank you so much. We need to wrap up for time, Dr.
Okay,
Langar.
sure. Just this, it's the here where we are with the vaccination. Israel is the first, followed by United Arab Emirates, targeting to have 70 to 80% of coverage rate. And the other countries are following, as you can see in this slide. Next, please. This is also the situation really detailed with in fact, the daily COVID-19 vaccination doses as per 100 people as per yesterday data received. Next, please. And just in conclusion, by 12 April, sorry, all countries who join at COVAX facility will be able to roll out the COVID-19 vaccine. There are currently 3 vaccines recommended by WHO. Some other vaccines are currently under review, and they will hopefully be accepted by WHO. And of course, WHO will continue monitoring the quality and the safety of the COVID-19 vaccine in post-deployment phases, because all vaccines are really approved for emergency use, and many data are still ongoing with regard to the safety and efficacy of the vaccines. I will stop here and thank you for your attention.
Thank you so much, Dr. Langar. Over to you, Ana Rita.
So, hi, good morning, everyone, and good morning to all the friends that I saw join this webinar, and the many health providers and WHO colleagues also I know are there. It's really a pleasure to be with you today with this inspiring panelist, and thank you very much to my colleague Hoda for this informative presentation, and I hope everybody benefit from this updated information. And I will try in few minutes to complement with some reflection from the public health perspective on possible risk and some consideration related to gender-based violence, and COVID-19 vaccine. Next, please. So in this first slide, I want to go very quickly one step back before digging into more specific vaccine-related consideration, and mostly for the WHO and health colleague that joined the webinar, and because for all the other, I'm sure this is very well known. As Jennifer mentioned, in the COVID-19 era, GBV has been called the shadow pandemic. And we saw a global report with dramatic increase of GBV. And from a health point of view, a survey we did in the Eastern Mediterranean region in April 2020 showed that health services have been receiving about 40% more of GBV survivors in need of different services, such as MHPSS support. Of course, they reported severe injuries and permanent disability and mutilation, such as female genital mutilation, as we saw, for example, in our survey in Somalia. So GBV is a systematic pandemic as it affects 1 in 3 women globally, and find its root in patriarchal norms, the imbalance of power, and gender inequality. Next slide, please. And why I mentioned the root of violence, because it's very important to keep these 3 elements in mind, not only when planning for GBV activities, but also and most importantly, when planning public health interventions, including immunization. Talking a lot with my colleague in WHO, the understanding is that usually immunization is designed to be a gender neutral process. However, we know that gender neutral doesn't mean gender equal. And so the same factor at the base of gender-based violence increase during COVID-19 may prevent a successful vaccination campaign and pose gender-related health security issue. So it's very important we take into consideration the social determinants of health, such as gender, to be key elements for a successful vaccination campaign. Next slide. So now thinking about some possible risk factors associated with the COVID-19 vaccine, and I will go quickly because I know my colleagues also will talk about this. We need to take into consideration restriction of movement, as Sophie mentioned, imposed by partners or family, whether women and girls are survivors of GBV at home or not, because this is in most of the country is part of the social norms. At the same time, the location of the immunization campaign is very important and needs to take into consideration the fact that traveling long distance may pose a risk of GBV, such as sexual assault and harassment, and so may deter access to vaccine for women and their children, because we also know from evidence that if women are not involved in the planning of the vaccine campaign and are not informed, their children also are most likely to be not vaccinated. Now, this is not the specific case of COVID-19, because we know that it's mostly for adults, but again, this is a factor that we need to take into consideration. And this traveling long distance may pose a threat for women health providers too, that have to reach the facilities to deliver the vaccine. And talking about female health workers, we saw how much they have been present in the COVID-19 response, and most of the time not sitting at the decision table. We saw that women represent 70% of the health workforce and will mostly be the majority of the health provider administering the dose and the vaccine delivery. And this could increase exposure to harm and increase workload. And this could turn also into pressure at home, because they will be likely to spend less time at home, less time taking care of their family, and so may be exposed of GBV, risk of GBV at home as well. Also, and especially in countries where we have gender sensitiveness, having facilities designed without taking into consideration gender-related sensitiveness and the issue of confidentiality may prevent again access for women and girls, and as mentioned and will be further elaborated, the increased risk of sexual exploitation and abuse is real. I know it's time for me to wrap up, so I will go to the last slide, which are some consideration that no, please, the one before. There's some consideration that every health system should take into consideration while planning immunization campaign for COVID-19. Definitely, our key message is that GBV services must remain open with sufficient staffing and funding to provide the essential life-saving services throughout all the vaccination process, and health providers should be trained on gender and GBV sensitive approaches and available referral pathways for GBV survivors. And this campaign could be definitely an opportunity for distributing GBV service information material, again, including referrals and services. And as we know from other experience that the sexual exploitation and abuse risk is real, we should ensure that reporting and services referral network functions. As for the last slide, I will just want to highlight one point of the last slide, because I know time is up, is that this is the first time we have a global vaccination immunization campaign at the same time all over the world. But not all the countries are the same. So there is not one recipe for everybody. And again, while designing this vaccine campaign, we need to take into consideration that it has to be tailored to country context with specific consideration for humanitarian settings. Thank you so much.
Thank you so much, Ana Rita and Dr. Langar. So now we have time for some questions, and we do have a question that's come from one of our GBV coordinators, in fact. I think we'll direct this to you first, Dr. Langar, and then our other panelists can come in. The question is, was GBV, and especially GBV frontline workers, considered in the design of the prioritization roadmap? And if not, is there still a chance to influence this either globally or at the country level? Over to you, Dr. Langar.
Yeah, thank you. To be honest, we are considering GBVB as a priority, and but for that, when we started putting the prioritization, it was really based on some principles. It's the solidarity, equity, and fairness. But for us, really the priority is to treat, to prevent persons who are at risk, at high risk, notably the healthcare workers, because they are in the front line. Regardless, we know there are women and men working as in the health system, donc they have to be protected. After that, we have all persons with comorbidities or aged. And for this, we are not really segregating or saying, even we are considering this some specific population, humanitarian population, refugees. But our target is really to prevent those that are risky in terms to when they get infected by, we don't want them to go to the ICU and to have complication and to develop severe diseases. Yeah, we didn't give particular attention, but they are in these different groups. This is the way we approach it from SAGE, let us say, perspective, and from the immunization experts. Over. Thank you.
Thank you so much. And would either of our other panelists like to come in on that question?
No, maybe just to complement very quickly on what Hoda says, that I mean, well, from an internal WHO perspective, I think there is an increased awareness in the organization, and an increase like consideration of gender and the GBV related aspect in the work of WHO, which in this case also include immunization. So it's really also us GBV specialists, how we reach out our colleagues, and now we make sure to, you know, make our points understandable for them, and so that they can really understand the importance of tackling gender and GBV issue for having a successful campaign. Over.
Thank you so much. Sophie, anything from your side?
Thank you. Yeah, I find that was Dr. Langer's response actually was quite interesting, because it sort of points to some of these problems around equity and fairness in health and vaccines, and this problem between the universal and the particular, because it's quite a narrow reading of risk. So it's risk of COVID, morbidities and mortality, whereas obviously the risk of COVID is the wider risk to society and exacerbated risk around GBV. And I think what's really helpful about this conversation is saying, okay, so how can we reframe our understanding of risk in this context, and how can GBV be prioritized? Because if I'm understanding this right, it wasn't considered in the prioritization process, but will hopefully just be covered in this kind of universal at some point. So that to me suggests that it hasn't been thought about in terms of this prioritization. And please do correct me if I'm wrong, and this is not a criticism because this often happens, but it's how then do we suggest that there needs to be a prioritization for really at-risk groups that aren't seen just at risk of COVID-19, but at risk of the wider impacts of COVID-19. And I think that second part is something we're still wrestling with when we think about global health and the humanitarian sector.
Excellent. Thank you so much to all our panelists for answering that question. We're now going to have another 30-second moment of calm, and we can reflect on those questions and also be thinking about other questions you haven't asked yet, because we'll have another opportunity later in the webinar. Okay, thank you. We're back. We are now going to move to our second group of panelists who are going to dive in deeper, really speaking from personal experiences and looking at some kind of field level strategies we can apply to these issues that we've really framed in our first group of speakers. So now I have the pleasure and delight to introduce Tanya Fraser, who is a GBV frontline responder, as well as a sexual and reproductive health expert, and also is currently working as a gender mainstreaming consultant at the National COVID-19 Response Center in Sierra Leone. And I also happen to know she's a supporter of women-led organizations. So Tanya, over to you. We're eager to hear your lessons learned. I think we just need to unmute Tanya.
Sorry.
That's okay.
Good morning, everybody. Good morning, everyone. So I'm just going to dive in and talk about my experience and experience of response during the Ebola pandemic compared to the current pandemic that we find ourselves in. So in Sierra Leone, Ebola came to Sierra Leone in 2014. But prior to 2014, Sierra Leone already had one of the highest rates of teenage pregnancy in the world. And as a result of that, between 2007 and 2012, a range of laws were enacted, which helped address gender-based violence. And so they also developed a national strategy for the reduction of teenage pregnancy, because a lot of these cases were actually resulting in pregnancy, in young girls as young as 9, 10, and 11. But when the outbreak came, the primary focus was breaking the transmission of Ebola, as there was a high rate of deaths. And the outbreak actually placed a huge strain on gender-based violence-related services, in particular medical and justice services. So for example, I was heading a sexual assault referral center. One of them in a district in the east had to close for 3 months because it was next door to the Ebola treatment center, and it wasn't safe for the staff. We relocated, but it took 3 months to find alternative location. The justice services, because there were no doctors available, they were all on the Ebola response, and there were no doctors to do medical examinations and sign medical reports. So some cases were just thrown out of court for lack of evidence. And our community leaders and traditional leaders are used to mediating cases, even though there are laws, but this is what they normally do. This is where they get a lot of their powers, through mediation among their community members. And restrictions made it very difficult for people to report cases and access services. Because we had inter-district lockdowns, so we have 16 districts, and it was very difficult to move from one district to another. You had to have a special permission or something. Next slide, please. So the number of cases that we saw did not reflect what was happening on the ground, but the reporting increased as the number of Ebola cases reduced. And what came out of that was the majority of cases were sexual penetration of children. In Sierra Leone, rape is for adults or people above the age of 18. And if the survivors are below the age of 18, then it's sexual penetration. And this was all linked to the closure of schools. Schools were closed for over a year. Children were not being supervised as much as when they were going to school. And they had a whole, the communication campaign was trying to get people to avoid bodily contact using ABC. And there was a research that was funded by UNDP.
Tanya, we've just lost you for 1 moment. We'll give you a moment to come back, and our team will try to reconnect with you. I think we all can relate to internet outages. This is one of our new ways of working. We'll just give one more moment for Tanya to get back online.
Sorry, I think my internet dropped. Can you hear me?
Okay. Yes,
Yeah.
please go ahead.
And it's estimated that the increase in teenage pregnancy as a result was somewhere between 40 to 65%. So towards the end of the outbreak, donors came up with some 6-month emergency response to gender-based violence, and they included various organizations and other service providers. So I was working for an organization called Rainbow Initiative, and they had these Rainbow Centers that provided free services to sexual assault survivors. They included other organizations such as IASC and Handicap International. Next slide, please. In the interim between Ebola and COVID, a lot has happened. So in 2019, our president declared a state of emergency on sexual violence because the number of reported cases they felt was just increasing, and we had all these laws, but impact was not being felt. The Sexual Offences Act, which was done in 2012, was reviewed and has now been amended. And since some of the guidelines, some of the sentencing guidelines have been strengthened. So before, it was maximum of 15 years imprisonment, and now it's 15 years to life imprisonment. The other service providers came up. The Rainbow Centers have now expanded beyond the 3 original centers and have now opened 2 more centers. And the government itself has launched sexual assault referral centers, which they called one-stop centers, where you're supposed to access services, and you're also supposed to be able to get legal advice or representation, as well as any other necessary services that people might need. And they also launched a free hotline, which was 116. And the hotline and actually the one-stop centers were all launched last year after the start of the COVID pandemic. Next slide, please. So I think for the response, it encompasses several agencies. So I'm working for the National COVID Emergency Response Center, which looks at testing, treatment, communication, and psychosocial support. But there are other agencies like various ministerial departments who are also involved, sometimes at arm's length. And so we have the Ministry of Education, we have the Ministry of Gender and Children's Affairs, and so forth. So we've learned from the Ebola that closure of schools is very damaging for children, especially for girls. So even though school was closed at the end of March last year, we were very aware that we had to find a way to ensure that schools reopened as soon as possible. So in June, July, mid last year, they started opening some of the schools for some of the classes, especially for those who had public examinations to do. So they started opening schools in phases, and it was staggered. And so it was something that was definitely prioritized by the ministry, and guidelines were also developed. And the infection prevention control pillar at the National COVID Response Center worked with the Ministry of Education to train school focal persons on IPC and also on COVID-19. Other pillars, such as the risk communication and social mobilization pillar, developed a training manual for community-led action because we wanted community members and leaders to actually own information, sharing of information, dissemination, and among the various communities. And one thing which was definitely recognized, which was not spoken about during Ebola, was also about mental health. And how do we keep health workers safe and ensure their mental health is of paramount, and also of communities. But also some of the things we realized is each pandemic is very different. And the challenges that have arisen is because COVID is quite different from Ebola. So some of the things we've observed is there's some mothers who've had to be taken to treatment centers who had to go with their young children because there was nowhere safe to leave a 1-year-old baby or a 2-year-old toddler. We haven't seen any significant increase in gender-based violence to date, but that might be because young girls and women are at home, have been at home with, maybe the alleged perpetrators are also homebound with them. There's been, so people have not actually been reporting as much as we noticed during Ebola. We're not sure if, after the response or after the pandemic has more or less subsided, that we are going to see an increase in the number of reported cases. Next slide, please. So my next 2 slides is to conclude, just to show you the risk communication, the type of communication messages that they've developed. So this is one of them. They had a big idea of the week, and specific topics were addressed each week, and talking points were also developed. So partners could go out into communities or actually out into the media, on radio, on television, using the talking points to educate people and to answer various questions. So between the 18th and the 24th of October, the big idea of that week was mental health is key part to getting through this Corona time. Next slide, please. And the final slide was about was violence. So which came in September, and it was violence is everyone's business. Do not keep silent, look out and speak up. And this was something which I encouraged, because I had to remind them that, look, we have to get people to report. We're not seeing any increase in reported cases. We're not sure if the reason for that, but how do we ensure that anyone in the community, not only women and girls, but also men and boys also have a role to play? And we knew that people were stuck at home with other members of the community, because people live in huge compounds which have multiple households, and there are a lot of vulnerable people as well who might be facing neglect or sexual violence. So these flyers were also developed and shared among partners, so they could go out into the communities and into the media, onto the radio, and talk about these particular issues and educate the public. Thank you very much, and over to you.
Thank you so much, Tanya. Those practical examples are just gold. We really appreciate you sharing them, and I think we'll come back to them in the Q&A. Now I'd like to hand over to Masumi Yamashina, Child Protection and GBV Specialist with UNICEF. And Masumi works with various clusters at the global cluster coordination level to integrate GBV risk mitigation into sectors. And I've seen her work firsthand from Juba to Kabul, and she is truly an expert. So over to you, Masumi. We're eager to get your advice.
Thank you very much, Liashre, for this general introductions. Hello and everyone. My name is Masumi Yamashina. I will talk more about GBV risk mitigation within our vaccinations. So gender-based violence is just simply a good programming. It helps health actors to increase immunization coverage and also reach to hard-to-reach clients. It also ensures that any setup for vaccination is safe. So this is very simple. So how do we do that? First of all, first step is to understand gender-related barriers that women and girls face in accessing vaccination, both information of vaccinations and vaccination itself. We do have our good framework, barrier analysis framework called availability, accessibility, acceptability, and quality framework. We adapted it from health sector. So I think most of health sectors are health actors are familiar with the framework, but we have adjusted the framework to really tailor to the women and girls specific barriers to different services. So this framework can be used to analyze what are the barriers that women face in information of vaccines and also the vaccination itself. I will give you some example of barriers that our women and girls faced in past vaccinations. Already some of the other presentators mentioned, but husband approval, it's always important in many, many contexts. And also lack of female vaccinator, simply as simple as that, will also prevent women to accessing from vaccinations. And also simply lack of prioritization of women's health. That's kind of deprioritizing the vaccinations for targeting women's, etc. And also in many countries, sadly, the women has lower literacy rate than men and a lower access to mobile phone and network than men. So it makes it difficult for women to access vaccination information if it's all, for example, are done through our mobile phones or networks and digital, or written, or information is focusing on written, in just our letters. So we need to really consider those aspects, because also this will also make women vulnerable or to false information about vaccines, and they might get wrong information and they might affect their decisions to take the vaccines. And we have seen in the past vaccinations that women face, for example, domestic violence at home because they took their children to vaccines without husband approval. Or the husband see that women are taking children to vaccination and talk to male vaccinators. So it also really put women in dangerous, increase women's risk to face GBV when we are not considering those risks and barriers. And this time it's really, we are targeting, colleagues from WHO said, it's the first time that we have global campaigns and really targeting adults. So we might also expect additional barriers, especially for adult women. For example, some women face extra barriers replacing civil documents. In some cultures that women cannot replace their civil document without men. Without civil document or registration, they don't exist in national systems. So they won't be able to receive the vaccinations. It deprives opportunity of women to receive vaccinations, but at the same time, it is a failure for vaccination campaign because you will not reach out to women who are most vulnerable. So it's really important to consider that special barriers that our women has to have a successful immunization campaigns. And also, as we all know, that the current level of the availability of vaccination is not good. So we don't have vaccination for everyone in every country at this moment. So this scarcity really increases the risk of sexual exploitation and abuse. Also maybe the lack of prioritization of women or fear of maybe they don't receive our vaccination could really increase the risk of sexual exploitation and abuse. And as we all know that sexual exploitation and abuse could happen in all settings, but this kind of setting where we are talking about life-saving interventions with very scarce resources, risks are even higher. So we cannot take care of we should take the best care, best measures to prevent sexual exploitation and abuse. So I talked about gender-related barriers, but what else can health actors do? And I also will talk a little bit about what GBV actors can do with health actors. First of all, for health actors, it's really important just to have this awareness that potential risk that vaccination campaigns and vaccination itself could cause. Even with the best intention, when we don't think about these barriers and risks, we could always cause harm. So it's very important to have this awareness. And then also the best and simple strategy, I think Tanya also mentioned, is really working with women. sadly that we know that most of national kind of COVID-19 response or mechanism do not have adequate women. And we see the result is really huge. That's little allocation of a budget to GBV, or little consideration of special needs of women and girls. So that really the best strategy is to have women in all decision making and planning of vaccinations, coming from the community level to the highest level of the countries. It is really the best strategies. And so in a community level, you might have a challenge of how to engage with women. Then really work with local women's organizations. They know the barriers. They know how to reach out to women. So really as simple as working with local women's organization makes it very strong to bring women's perspective. And also just for GBV, it's really important that GBV actors and health actors work together in planning and then the implementation of vaccine campaigns. For example, for some of women who are experiencing GBV, it might be the only opportunity to seek support. So it's absolutely necessary that the vaccinators knows how to do the GBV referral, the basic information, and put, for example, our posters where they can seek support, the hotline numbers, etc., so that women can seek support and get information. And that's where the GBV actors and health actor can work together. And just for the PSEA, Sonia already mentions that we really, all vaccinators must sign the code of conduct and trained. Signing code of conduct is not enough. All of them should know what's their obligation and what they should not do. And also for our vaccination promotion campaign, it's extremely important that we include the messages that women has a right to receive vaccinations and no one can ask anything in exchange of vaccinations. And also information that are how to complain, how to file the complaints in case such things happens. But it's really important that whatever the campaign, we really make sure that to really, emphasize that it's their right and no one has a right to ask you to do anything otherwise, because it's sometimes, this message is important, but it's not necessarily available in every campaign. So thank you so much.
Thank you very much, Masumi. I mean, you gave us some very clear strategies and clear messages to take forward. So now I have the great pleasure to introduce our GBV AoR speaker today, Pamela Marie Godoy, and I have the honor to work with her every day here in the Asia Pacific as a member of our REGA team. And she's going to take us through some of the guidance we developed collectively for this webinar. Over to you, Pamela.
Thank you, Lee Ashley. So the GBV AoR has developed 2 documents in collaboration with World Health Organization and UNICEF. The link is in the chat box. Firstly, we have a matrix on possible GBV risks and proposed actions that can be taken. And secondly, we have a document with key messages and advocacy points. Both of these documents are living documents and they will be updated as new information becomes available. So key entry points for GBV subcluster coordinators are through the health cluster and intercluster coordination groups. There will also be government-led coordination structures like COVID-19 task forces and national immunization advisory groups. These government-led structures may be preoccupied with decisions on indemnifying COVID-19 vaccine manufacturers, supply chain management, and logistics. So it's crucial to find strategic entry points for advocating for GBV risk mitigation and for women's meaningful participation so that their voices are heard in these decision-making processes and spaces. In relation to protection from sexual exploitation and abuse, so work with PSEA task forces in country to integrate up-to-date GBV referral pathways for life-saving care and support within PSEA complaint channels. With regard to risk communication and community engagement, we know that the COVID-19 pandemic has fostered the spread of misinformation at the time when facts are crucial and life-saving. Some rumors have actually created a significant public health risk by stigmatizing protective practices or reducing trust in healthcare providers. So in this case, what are the rumors and misinformation that are currently circulating in communities about COVID-19 vaccines? For instance, there are rumors about COVID-19 vaccines and fertility. Some societies which perpetuate evaluation of women based on their fertility consider infertile women to have been cursed and in general perceive barren women in a very negative way. So we have to be on the lookout for these infertility-related rumors around COVID-19 vaccines, as this can stigmatize women and increase relationship stress and tension between intimate partners, which may lead to violence. So there's a need to work closely with RCCE working groups or task forces at country level on real-time rumor management system and the appropriate communication response. The COVID-19 vaccination will be a massive undertaking, and similar to what happened last year, we may see the diversion of human resources and physical facilities to the vaccination program. We should continue advocating to ensure that essential and life-saving GBV services are continued and even expanded based on demand. For those that are delivering in-person GBV services, availability of and access to infection prevention and control supplies, including appropriately sized and designed personal protective equipment, should be ensured. And for those GBV services that shifted to remote service delivery, like phone-based GBV case management and hotline services, adequate staffing and support should continue to be provided. When you encounter pushback, please reach out to the Riga team in your respective region, and the GBV AoR will coordinate with WHO, UNICEF, and other core members to support you with the necessary information and to continue the advocacy for equitable access to COVID-19 vaccines. Again, the documents that we shared are in the context of collective and iterative problem solving, and will be updated based on field level experience. So thank you. Over to you, Ashley.
Thank you so much, Pamela. So now we're going to have just a final 30 seconds of calm. We've shared another scene from Asia Pacific with you today, the Himalayas. So please take a moment, reflect, gather your questions, and we'll have a final round of questions and discussion. Okay, thank you, everyone. Now we have a couple of questions that have been submitted so far. I'm going to go back to you, Dr. Lungar. We had a question about how do pregnant and lactating women fit into the prioritization? Over to you.
Thank you. Do you mean with regard to the vaccination?
Yes, I believe so.
Yes. For the time being, due to the fact that there are no data available coming out from the clinical trials that were conducted, there is no recommendation for pregnant women to get the vaccine. This is for the current available vaccines. However, if there is a very high risk to a pregnant woman, like if she's a healthcare worker and she's really in front of and dealing with infected COVID, with the COVID virus. It will be case by case, and she will get the vaccine. This is the recommendation that we have for, as of today. Over, thank you.
Thank you so much for responding to that. And we have another interesting question, some of which has been answered in terms of what are the lessons learned and key advocacy messages. I believe Masumi and Pamela have spoken to advocacy as well as Tanya has spoken to lessons learned. But we also have a question about to what degree have our advocacy messages and our planning and thinking today really integrated the consideration for women and girls with disabilities? And I think we have not done enough on this yet. So I'd like to open up to our panelists and ask, do you have specific recommendations or things that you really think we need to move forward to ensure that women and girls with disabilities specific needs are considered? I will start with Masumi on this one, and then we can move to the next panelist.
Thank you, Leah Shule. I think it's a great point, and thank you so much for asking these questions. I think the AAQ framework can be used again to really understand their specific barriers to accessing our information on vaccine and vaccination campaigns. And I know also disability sector, they use the same framework. So when we analyze or when we work with health sector to analyze barriers, let's make sure that the specific barriers of our women and girls with disabilities are also included, and then to address their specific barriers. Thank you.
Thank you, Masumi. Would any other panelists like to come in on this question? Okay, so I would also stress that the guidance that Pamela shared, as she mentioned, is iterative. So please do share your thoughts. And I think this is an area that we can improve in that guidance. So share it also with the groups that you work with so we can make sure those are considered. Excellent. So now I don't see any further questions in the Q&A. So I'm going to move and turn the tables and ask you, our participants, a question. So I'd like to hear from you. What do you think are the most strategic steps for integrating and applying all the things that we talked about? And that could be at country level or also at regional or global level. So if there are any participants who'd like to share a few thoughts on this, please feel free to write in the chat box or also raise your hand and we will unmute you to share your questions, to share your answers to this question. You weren't expecting that you would be asked a question maybe. So the floor is open for anyone who would like to recommend some next steps. Okay, so we did think that this is a big, tough question to ask. So not to worry, if you would like to reflect on this, we're actually going to be sending out a survey after this webinar today to all registered participants, and this question will be there. So please do take some time and fill out the survey and really share your thoughts with us. And that will also help us follow up on your recommendations and know how we can really move forward after this webinar. I do see, Ana Rita, your hand is up. Would you like to share?
Yeah. Yes, can you hear me?
Yes, please go ahead.
Yeah, no, I will leave this question for participants because we are really interested in knowing their ideas and thoughts. I mean, just one recommendation always from a GBV specialist working with the health people and health provider. Sometimes it's just an issue of, in terms of advocacy, it's just an issue of reframing and rephrasing the language and make sure that we also translate our concept and our needs into a public health language so that we can get our public health colleague involved and really understand what we are doing. So what I really advise for all GBV practitioners is sitting with your health colleagues in countries where you operate and try to translate your needs and your ask into a language that is understandable for them and that makes sense for them, so that it can be more easily, you know, understood and also uptaken over.
Thank you so much, Anarita. I totally agree. And we have lots of suggestions coming in the chat box. Thank you so much. I see that some of our GBV coordinators want to take these advocacy messages forward at the country level with their specific GBV coordination groups. Excellent. And also there's a very interesting recommendation that we need to think about awareness raising in schools. And I think, Tanya, you touched on this, and how that would work in the midst of these things to make sure that messaging reaches children, teachers, and parents. And we'd also encourage you to continue this discussion on our GBV AoR community of practice. Today is just a start, it's not an end. And I also see a really interesting suggestion about, so there's lots of discussions globally about shelters, detention, elderly care facilities, but no focus or prioritization for emergency safe shelter for GBV survivors. And we should advocate for the inclusion of them too and vaccination action plans. And I think this is really a lesson learned from our first phase of COVID, that these emergency shelters, detention centers really need specific consideration. So thank you for sharing that, and we'll definitely be taking that idea forward in our thoughts and also in our guidance. Yes, and awareness raising through posters, radios, TV advertisements, absolutely. Thank you, Akila. Great. Okay, I'm so sorry we don't have time to hear from everyone on the webinar today, but there is an opportunity for everyone who's attending this webinar, and also for those who join through YouTube later, to fill out the survey and share more thoughts on this question. So unfortunately, I need to move to our last slide to wrap us up for today. And I'd really like to thank all of our panelists who dedicated their time and expertise to ensure this webinar happened. I would like to thank you as our participants. I think this was really useful dialogue. And I'd also like to thank the entire GBV AoR team. There's a whole crew of people working behind the scenes today to make sure that this happens. And a special thank you to our interpreter and our captioner, who have really done an excellent job and helped us learn how we can make our events more accessible. So just in closing thoughts, I think we've identified a number of challenges, and perhaps it might even seem a bit daunting to respond to this issue that's really on such an unprecedented scale. But I'd like us to close with the idea that we have a real opportunity before us now. And we also have this shared set of common humanitarian principles to move us forward. So I'm sharing this quote with a fierce woman leader and the head of the WTO, Ngozi Okonjo-Iweala. And I think it's something that really helps us understand what we could and what we should do. So to close, let's think about how we can bring everyone up. That's all for today. Please stay safe, stay well, and please stay in touch. Thank you.
Thank you, bye.
Thank you.
Thank you, everyone. Great job.